We'll start it with the discussion around Alport's syndrome and let's say, the classic version of it arising from a mutation in the call4A5 gene. Okay. Um, so the Alport's syndrome is most commonly this X-linked form, okay, arising from a mutation in the call4A5 gene. Let's do some background on how collagen is genetically coded, and mature collagen is expressed in kidney tissue. So collagen is a macromolecule that is made of several different subunits. We're talking in this case about type 4 collagen. There are multiple collagens throughout the body. For type 4 collagen, this mature protein arises from the interaction of three different proteins. That is the alpha 3, alpha 4, and alpha 5 chains that make up this mature type 4 collagen. Okay. They wind around each other, forming a triple helix. And this type 4 collagen is found in many tissues, not solely the kidney, but certainly is found in the glomerulus, the lens of the eye, and also the inner ear. Okay, and that would explain some of the phenotype that we see in Alport syndrome. Okay, now there are other ways that one can assemble a collagen protein, and that can be through the derivatives of alpha 5 chains, the same alpha 5 chain that complexes with 3 and 4 in the glomerulus, lens, and organ of Corti. But alpha 5 can also complex with alpha 6 to make up other structures, including the basement membrane of Bowman's capsule, as well as the basement membrane of distal tubular structures and in the skin. Okay, that seems like tedious factoids, but it's going to become relevant as we discuss, for instance, how you can diagnose some of these collagenopathies through skin biopsies, where you can distinguish different forms of Alport's or thin basement membrane. Okay, so keep that in mind. All right. So again, the genetics of Alport syndrome is primarily based on mutations in the call4A5 gene. That is the gene that codes for the alpha 5 chain of type 4 collagen. Okay, call4A5. 4 referring to type 4 collagen, alpha 5 referring to the subunit that is most commonly mutated in Alport syndrome. Now, there are other forms of Alport syndrome that can arise from mutations in alpha 3 chain or alpha 4 chain. Okay, this could have autosomal recessive inheritance, meaning you have to have mutations in both alpha 3 chains, or both genes coding for alpha 3 chains, or both genes coding for alpha 4 chains. Okay. When you have a single mutation, right, not two, a single mutation, these individuals will often express what we call thin basement membrane disease. Okay. What is thin basement membrane disease? Typically, not always, a fairly benign condition characterized by recurrent either gross hematuria or microscopic hematuria. Okay, but generally good renal prognosis. So again, you can see already that there's getting some confusion here. I'm saying that if I have one mutation in an alpha 3 chain of type 4 collagen, I might call that patient thin basement membrane disease. If, on the other hand, they have two mutations in alpha 3 chain of type 4 collagen, I might call it a wholly different disease, Alport syndrome. So again, you can see already things are getting confusing with the nomenclature, and there's not great agreement on exactly what we should be calling these things. Okay, so when you're making diagnoses at the bedside, it may be more appropriate to just discuss these patients in terms of what genetic abnormalities they have, right? You could say this is a patient with CKD, proteinuric CKD, FSGS on kidney biopsy. By the way, these patients will often show FSGS on kidney biopsy with two mutations in the alpha-3 chain of type 4 collagen, okay? They can also have, in lesser frequency, autosomal dominant inheritance, whereby I have a mutation in only one of the genes coding for alpha-3 chain or alpha-4 chain of type 4 collagen, and that itself is now able to express disease. Here again, look at all this confusion. You're telling me if I have a mutation in the alpha-3 chain and I only have microscopic hematuria, I should call that thin basement membrane disease. However, you're telling me on in another dimension that if I have only one mutation in the alpha-3 chain of type 4 collagen and they have a more severe phenotype, I should call it Alport syndrome. Well, what about that thin basement membrane disease that doesn't have a benign course, where at the age of 30 or 40, they actually have proteinuric CKD with a creatinine of 1.6. We have these patients in our GN clinic. That is to say, we have thin basement membrane patients that have a totally benign course, microscopic hematuria with preserved GFR. We have some patients with a single mutation in alpha-3 chain of type 4 collagen, and they have a creatinine of 1.8 and proteinuria. I forget, I guess this is Huzair, who's on um, Parkland Consult now, and he is currently managing a patient who's in the hospital with a creatinine of 6 in her 20s, and she has, if I remember correctly, a single mutation in one of these. I forget, it's the alpha-3 or alpha-4 chain of type 4 collagen. So she has a very severe phenotype. Again, what do we call her? Do we call her, again, Alport syndrome? Do we call her just severe thin basement membrane disease? Or we simply call her, collagenopathy from type 4 alpha-3 mutation in an alpha-3 chain of type 4 collagen with severe CKD. So again, you'll see how all of this is getting muddy, all right? I've highlighted the variability in course with, again, an example that's currently on the consult service. If I remember correctly, she has only a single mutation in one of these alpha-3 or alpha-4 chains. But again, she's in her 20s and she has a creatinine of 6 now, okay? Again, there's a variability of causal mutations. In general, larger deletions result in more severe phenotype. You'll recall that similar pattern in autosomal dominant polycystic kidney disease. And be aware that there's another complexity to this genetic underpinning of the disease. Remember, if I have a mutation in the type 4 collagen alpha-5 chain, this resides on the X chromosome. So that means if I'm a male and I inherit this mutant allele on my single X chromosome, I don't have a normal second X chromosome to defend me against severe manifestations. That's fine. It makes sense. I'm a male. I develop severe CKD early in life, even terminal renal failure. Okay, that makes sense. But if I'm a female and I have one normal X chromosome, one abnormal X chromosome bearing a mutation in the alpha-5 chain of type 4 collagen, then I may have a fairly benign course, just recurrent hematuria. But if I'm so unlucky that it turns out that I inactivate the normal X chromosome that is coding for the primordia that ultimately evolves into my kidneys during development, I may have a more severe phenotype. So you'll recall, I hope, that in development of the female human, the X chromosome, one of the X chromosome is essentially deactivated. That's called lionization. Okay. And so if you're happening to, and that is not uniform throughout the organism, but if you're inactivating some of the X chromosomes that are going to be ultimately developing into the normal kidney, you can have a more severe phenotype in females. Okay. This is a much more rare genetic underpinning of this Alport syndrome, where you can have a mutation in a different protein, this non-muscle myosin, and that too can present with glomerular basement membrane abnormalities, progressive CKD, and then also some other features, hematologic features, large platelets, that are fewer in number, as well as some white blood cell inclusions. Okay. Now, let's then transition from that genetics over to some presentation. It should map back to some of the conversation we just covered regarding genetics. You, of course, don't always have a family history, right? Because I can have a new mutation, right, in an index case within a family. So I may not have a family history in 10% of cases of Alport syndrome, genetically proven Alport syndrome. So these individuals, and this really refers to primarily the classic Alports from X-linked disease, these individuals will have hematuria detectable essentially in all cases, okay, in early childhood. All right. So if you have a 15-year-old kid and there's no hematuria, you can be fairly certain that they don't have this. If it's a boy, they don't have X-linked Alports. Okay. ESRD is essentially a certainty in patients in boys with X-linked Alport syndrome. Okay, and it happens in early in life, before the age of around 35. Okay, when I have other genetic causes, for instance, with autosomal dominant disease, I develop ESRD later in life. Okay, extrarenal manifestations. We talked about where these type 4 collagens end up. It's not just in the glomerulus, but you also have type 4 collagen in your eye, in your ear, as well as in your skin and in the Bowman's capsule and tubular basement membrane. Hang on to those last factoids. Again, we'll return to that as we're discussing how you might have distinguish between thin basement membrane and Alport syndrome based on skin biopsy, as well as immunofluorescence on kidney biopsy specimens. But we see anterior lenticonus. Okay. What does that refer to? On the lens, it's actually anteriorly protruding, not the cornea. The lens of the eye has this anterior protrusion that is visible to an ophthalmologist. And then you can also see some retinal changes. Those are more common than the changes in the lens. You can have some alterations in cornea as well. Okay. Hearing loss happens also very commonly. And even in thin basement membrane disease, you should do screening audiometry in patients. But in X-linked disease, in a male, they will require hearing aids. They will have profound hearing defects, and that will occur early in life. Okay, it starts out with just high frequency hearing loss, and then progressive hearing loss in youth for X-linked disease in a male. Okay, and you may have these abnormal growths of smooth muscle leiomyomas in X-linked disease as well. Okay. Thin basement membrane disease. Remember, it's hard to sort of parse these categories because of this blending of genetics and phenotype. But if I have an individual who has, a alpha 3 chain mutation in type 4 collagen, they may have a mild phenotype that is manifest as hematuria. Some of them will have hearing loss, right? And then even those that have, an alpha 3 mutation in type 4 collagen, or remember a female with X-linked disease, right? A female that has two X chromosomes who's a carrier for the alpha 5 mutation in type 4 collagen will have a mild phenotype that looks like thin basement membrane disease. That may be manifest as just recurrent hematuria, um, mild penetration in the phenotype of hearing loss, but you should do the screening tests. And then even some of these are going to develop ESRD. Okay. Now that Huzair is here, the patient that has autosomal dominant hypocalcemia and also a mutation in collagen, does she have a alpha 3 or alpha 4? She has an alpha 4, and it's a single mutation. Is that correct? Yeah. So you can, what do you call that patient? Severe thin basement membrane disease or autosomal dominant Alport syndrome? You can see again, the nomenclature is very messy here. Okay. But she clearly doesn't have, you know, benign hematuria, as thin basement membrane is also called, right? It's a misnomer in her case. She's not benign. Okay. All right. So let's look at renal pathology. Okay. In early stages of Alport syndrome, you'll see on electron microscopy this basket weaving characterization of the glomerular basement membrane. You can see these kind of lamellations, and it's disordered. This is called the basket weaving that we see on electron microscopy, a thickening and disorder to the glomerular basement membrane in Alport syndrome. Okay. Now, interestingly, you have in the interstitium occasionally these so-called foam cells. Why these develop in Alport syndrome is not clear, but is also part of interesting renal pathology findings in this condition. Okay, those are the early things you might see, right? Early lesions. I might see, actually, the earliest lesions, as I've written here, is that I might just see thinned basement membrane on electron microscopy. Okay, but as it progresses, you will see this disorder to the basement membrane. Okay, and then later, I not only develop this splitting, but I see on light microscopy focal segmental glomerulosclerosis, right? This wastebasket term, it's not a diagnosis, it's really just pathologic features, a fancy way of saying I see scar everywhere, okay? I see scar that is focally distributed, okay? Pranav, what does focal distribution mean? How many? Less than 50% of glomeruli have this lesion, whether it be glomerulosclerosis or endocapillary hypocellularity. And then, Alvin, what does segmental refer to? Perfect. Yeah. So within each glomerulus, I see it less than 50% of the glomerulus involved, a segment of the glomerulus, right? So this is just saying I see focally and segmentally distributed scars on light microscopy. Okay. Non-specific finding. All right. Immunofluorescence. Now, this is not done as standard practice. You would have to ask for immunofluorescence, looking for these alpha chains from your renal pathology. And then now we also have genetic panels like renocyte testing where you can make the diagnosis as well. Okay. Now, if I have, X-linked and autosomal recessive disease, means I have a mutation in both alpha-3 chains, or alpha-3 genes, or I have a mutation in both alpha-4 genes, right? That would be autosomal recessive disease, right? Not an autosomal recessive carrier, right? So if I have X-linked disease, right, I'm a male, I have my one X chromosome carrying the abnormal alpha-5 mutation, that would be disease, right? I'm not a carrier. I could be a female with one abnormal X chromosome, one normal X chromosome. I'm calling that carrier. So X-linked diseased or autosomal recessive disease means I'm a male with my one abnormal X chromosome, or I'm a male or female and I have two mutations in alpha-3 or two mutations in alpha-4. Okay, that would be X-linked disease. Sorry, autosomal recessive disease. Okay, these individuals will not see alpha-3, alpha-4, or alpha-5 chain staining in the glomerular basement membrane. Okay, so if I have, again, this mutation either in alpha-5 or alpha-3 or alpha-4, right? I'm using the term or. I see none of these in the glomerular basement membrane, right? Because you need all three to express the mature type 4 collagen in the glomerular basement membrane made up of alpha-3, 4, and 5 chains, okay? So that's the most common thing that you're going to see, right? However, in some, you'll see reduced expression, okay? But most commonly, you'll see the absence of all three. That means, again, even if I have a mutation in alpha-5 chain, if I asked my pathologist, I'm a male with an X-linked Alport. If I ask my pathologist to perform immunofluorescence for alpha-3 on my glomerular basement membrane, I'm going to see it there. Okay? Now, if I look, however, for alpha-5 chain in other places, remember I told you alpha-5 chain complexes with 3 and 4 to make the glomerular basement membrane and to make intact components of the lens and the inner ear. But alpha-5 can complex with alpha-6 to make up the Bowman's capsule basement membrane and basement membranes in the renal tubules, as well as the skin, okay? So if I have autosomal recessive disease, that means I have a mutation in alpha-3 or alpha-4, right? I have both of those knocked out, both of my 3s or both of my 4s knocked out. That's autosomal recessive disease. Then I can see alpha-5 chains in Bowman's capsule and the tubular basement membrane. Why? Because alpha-5 is there with 6. Okay? Everybody get that? If I have a mutation, however, in alpha-5 chain, I, of course, don't see that. I see negative alpha-5 staining in the GBM. I see no alpha-5 staining in Bowman's capsule. I see no alpha-5 staining in the distal tubule. Okay? If I'm a carrier, right, of the X-linked mutation, right, the alpha-5 mutation, then I might see discontinuous staining, less than normal staining, or immunofluorescence, I should say. It's not staining, for the alpha-5 chain. Okay? Moving now to skin biopsy findings. In X-linked disease means I'm a male with my one alpha 5 chain that's inherited and abnormal. Okay. Then I'm going to see no alpha 5 chain on a skin biopsy. Okay. So let's bring that back to the bedside. If I have a child who I'm worried about, Alport syndrome, and obviously they're worried about undergoing a kidney biopsy, I can actually perform a skin biopsy and look for alpha 5 staining in the epidermal basement membrane to make a presumptive diagnosis of Alport syndrome. If I have a young kid who has proteinuria and hematuria, and I say, I think you have not IgA nephropathy, that's another possibility, that you have Alport syndrome, okay? I can make that diagnosis by doing a skin biopsy. I can also do genetic testing, but I can do it with this less invasive procedure as well, okay? Autosomal recessive disease, that refers to alpha 3 mutations times 2, or alpha 4 mutations times 2, right? Autosomal recessive disease. I will see alpha 5 chain staining in, or I should say immunofluorescence, in the epidermal basement membrane again. Okay? So again, you can think about whether skin biopsy is going to be helpful in these scenarios. Again, the X-linked carriers has this discontinuous staining. Okay?
To do a genetic test, like I guess it gives you whether it's sexual chromosome or not, and then which alpha, like the patient invitation, and then you follow the family tree and then decide whether this is recessive or dominant, or do they give you the information it's like recessive or dominant?
You had a couple of questions in there. I guess I'll start with, the recessive versus dominant inheritance. Yeah, having a family history, of course, again, you can be an index mutation. And so it's hard to sort of say whether it's recessive or dominant. But the presence of multiple family members with kidney disease would imply either consanguinity in a recessive condition, or you would have, a dominant genetic mutation, right, that manifests with dominant inheritance pattern, right? And then you asked, will my renocyte result tell you whether it's autosomal dominant or recessive? And the answer to that is, in general, yes, although the number of mutations in alpha 4 chains, sorry, of type 4 collagen, either the alpha 3, 4, or 5 uh, genes, are increasing in number, okay? And I forget whether she had, I remember her autosomal dominant gene, I'm sorry, her autosomal dominant hypocalcemia gene was categorized as a variant of uncertain significance. And I said, no, this is significant in her because she's got the profound hypocalcemia. But I don't remember whether, I think it did actually say that this is pathogenic. Yeah, it says this is pathogenic. I don't remember whether it said this was an autosomal dominant mutation or not. Okay. But you will get that clue. But suffice it to say that we continue to learn more about the genetics of kidney disease. Driving that point home is a fairly recent New England Journal paper that looked at patients who had I forget what they called it. It was basically kidney disease of unclear etiology, something like that. Okay, and they performed genetic testing on these patients in a very liberal way. And they found that many of these patients who have so-called kidney disease of uncertain significance, um, kids and adults, have a fairly common incidence of mutations in type 4 collagen, 3, 4, and 5. That group was one of the most common genetic abnormalities found in this cohort of kidney disease of uncertain significance. Okay, so what does that mean? It means that you may get, uncertain information from a arenasite test where it says it's even a variant of uncertain significance. And then you're going to have to determine, well, you have thin basement membranes on kidney biopsy and proteinuria. This is a variant of certain significance in you, okay? All right, so how do we treat these patients? We treat them with ACE inhibitors and ARBs. There are some clinical trials that are underway for treating these conditions, but for now, we just have antiproteinuric therapies and good blood pressure control. Okay. Now, let's take say a few words about this so-called post-transplant anti-GBM disease. This is interesting and, somewhat complicated. So, get your thinking caps on. Okay. Now, the classic good pastures antigen, okay, is direct where you have an autoantibody in a non-transplant patient, a native kidney patient. You have an autoantibody produced to the glomerular basement membrane. They can have, Crescentic GN. They can also have pulmonary capillaritis, right? Or they have alveolar hemorrhage. So that antibody is typically directed towards the alpha 3 chain of type 4 collagen. Okay, and just so that you can see it in your notes here, this is the so-called good pasture antigen. Okay, so the protein product of this alpha 3 of type 4 collagen gene is the typical target for the native kidney good pastures disease, okay, or anti-GBM disease. Now, with post-transplant anti-GBM disease, you typically have antibodies to different targets, okay? So what is happening here? Well, let's say I'm a male and I had Alport syndrome and I developed ESRD at age, 20, okay? And then I undergo kidney biopsy, sometime later, right? I now have a kidney that from the donor that has an alpha 5 chain to type 4 collagen in it. I have never seen that before, meaning my immune system has never seen a normal alpha 5 chain to type 4 collagen. But now I do see this, okay? I see this new antigen, right? And now I can start producing an antibody to that alpha 5 chain, okay? So that would be one classic way in which post-transplant anti-GBM disease may happen, okay? And can result in crescentic glomerulonephritis, okay? Now, when you check for anti-GBM antibodies, it is typically done through an ELISA to that alpha 3 gene product, okay? The so-called non-collagenous domain of alpha 3 collagen, okay? So your anti-GBM antibody is likely to be negative, all right? You can actually check for anti-GBM antibodies by immunofluorescence, where the lab actually has a glomerular basement membrane looking for an immunoglobulin, typically an IgG, that is creating a linear staining on the glomerular basement membrane. Of course, also, you would make the diagnosis based on the biopsy that you did on the patient, right? What else could it be if the patient had underlying Alports? You do a biopsy, you see crescentic GN. What are you going to see on immunofluorescence in that patient? Sophie, what do you think you'll see on immunofluorescence in that patient? Did a biopsy on a transplant patient who's post-transplant GBM disease. Okay, they have crescentic GN on light microscopy. They have immunofluorescence. What would you expect to see on immunofluorescence in this anti-GBM disease? What pattern? Yeah, so would you see mesangial staining? Would you see glomerular deposits? Deposits is not the right word. Granular, immunofluorescence along the glomerular basement membrane. Would you see linear staining of immunoglobulin in the glomerular basement membrane? Granular staining is what you see when you have immune complexes, okay? And when you have anti-GBM disease, we're going to get to this, you will see linear staining on the glomerular basement membrane. Okay, that's classic for anti-GBM disease. Okay, now, what would you see on electron microscopy? Specifically, would you see electron dense deposits on electron microscopy? If I told you that in general, electron dense deposits are from depositing immune complexes, okay? Often this is circulating immune complexes start depositing in large quantities on a kidney biopsy. You'll start to see those electron dense deposits, okay? Another instance where you can see electron dense deposits is in membranous nephropathy. In that case, I have an antibody targeting an antigen. I have overproduction of that antigen. I have more antibody targeting more of that shed antigen. I see immune deposits in the subepithelial space. What do you think you'll see on electron microscopy for anti-GBM disease? You might think that, but when you see in situ deposition of an antibody targeting an antigen in the kidney, you don't generally see electron dense deposits. Electron dense deposits, if you're trying to, again, not just memorize and make sense of it, is typically indicative of large amounts of immune complexes, often that started as circulating immune complexes that are now getting deposited in the kidney, as you would see in lupus nephritis, as you would see in IgA nephropathy, okay? Membranous nephropathy is different. Membranous, you'll say, oh, that's an in situ immune deposit, right? An antibody that's binding PLA2 antigen. That's different. What is probably happening in that scenario that explains that is that you get an abundance, an upregulation of expression of PLA2, and then you keep shedding new antigen, more antibody is binding, more antibody is binding, more antigen is being manufactured and shed, okay? So that's a separate one where you do see immune deposits on electron microscopy, even despite this being an in situ antibody deposition, okay? Nothing other than GBM disruption, okay? You'll see ruptured GBMs. Okay. Okay. All right. Okay. If I have autosomal recessive disease where I have a mutation in alpha 3 chains, I might have the antibody to the alpha 3 chain. Okay. Now, this occurs in a small proportion of patients with X-linked disease, and it's usually when they have large deletions in that alpha 5 chain. And that makes sense because they'll have less protein expression and so are more likely to recognize that new gene product or alpha 5 chain as non-self. Okay. This happens typically early. We treat it. Treatment outcomes are typically not great. Okay. We often treat these with plasmapheresis. We'll give alkylating agents. Now think about that. You have a transplant patient who are already on calcineurin inhibitors and steroids. So we'll typically swap out the mycophenolate with cyclophosphamide and then try and turn the tide. Okay. Now, if you try to retransplant somebody who has post-transplant GBM disease, there is a high likelihood that they're going to have that um, process recur in the second transplant. Okay, I think we've covered a lot of the genetics that allows me to go through thin basement membrane disease a little more quickly. It is also a mutation, a disease arising from abnormalities in type 4 collagen, okay, just like Alport syndrome. These can be carriers of the Alport syndrome, right? What are the genetics of a patient that you might call thin basement membrane disease? Remember, again, there's this blurring of lines. So, that being said, I'll still use this terminology. If I'm a female with one mutation in my type 4, my alpha 5 chain of type 4 collagen, I might just have microscopic hematuria, preserved GFR. I might call that patient thin basement membrane, right? But what if that female has a male child, right? What is the likelihood that that male child may have Alports? 50%. Yeah. Okay. So now we're getting blurry again. The mom has thin basement membrane, but the male child we're calling Alports. You see how messy it is? Okay. All right. Or I might have mutations, typically single mutations in call 4A3 or call 4A4 genes. Okay, those would be often, again, expressed as a thinning of the glomerular basement membrane. Don't memorize this, I don't. Okay, as well as intermittent ruptures in the basement membrane that may be visible on electron microscopy. Okay, and notice that even though genetics haven't been performed on everyone in this group, some biopsy series have found an incidental finding of thin basement membranes in 5 to 10% of the population. Although, again, this is not genetically proven thin basement membrane disease. I'm just highlighting how thinning of the basement membrane is actually pretty common if you were to look for it rigorously on kidney biopsy specimens. Okay. Presentation typically presents with intermittent microscopic hematuria and then GFR that is quite preserved, right? That's the classic presentation of thin basement membrane. You can have gross hematuria. I don't like this term macrohematuria, but gross hematuria. And sometimes it could be preceded by an infection, making the diagnostic confusion arise where you're considering IgA nephropathy or even infection-associated GNs in your differential, okay? You can have acute kidney injury when you have gross hematuria and all of these red cells actually cause basically an obstructive nephropathy, a microscopic obstructive nephropathy, meaning I don't see a hydronephrosis on ultrasound, but if I were to do a kidney biopsy, I see tubules which are chock full of red cell casts. Okay, these individuals actually have hypercalciuria and hyperuricosuriia, and this might explain the increased incidence of nephrolithiasis in this patient population. Why this occurs is not clear. Okay, some patients will actually have fairly debilitating disease where even though their kidney function is quite preserved, they have severe flank pain, intermittent flank pain, to the point of, doctor shopping, chronic narcotic therapy. So these patients do present. That is distinct from the so-called loin pain hematuria, which is, I would say, a subset of patients with loin pain hematuria syndrome may actually have thin basement membranes on kidney biopsies. But many patients, many is not the right word, some of the patients with loin pain hematuria syndrome have so-called a nutcracker physiology where their superior mesenteric artery is impinging the left renal vein, okay, and causing a glomerular hypertension that might result in hematuria, okay, and others just don't have a good explanation, but have recurrent bouts of pain and hematuria, okay? Some patients, again, will develop a less benign phenotype with moderate degrees of proteinuria, hypertension, and then some of these even develop ESRD, okay, including that patient that whose air has on his service. If you were to do a kidney biopsy on these patients, they'll have FSGS on kidney biopsy. Now, how do we distinguish thin basement membrane or X-linked Alport's carriers from IgA nephropathy? Or how do I distinguish thin basement membrane from Alport's? That too is again is a messy distinction. Well, distinguishing it from IgA nephropathy, you typically will not have a family history of hematuria and Alport in IgA nephropathy. In Alport syndrome, these individuals will typically have that X-linked pattern of inheritance instead of this autosomal inheritance of thin basement membrane, trying to avoid dominant inheritance. But let's just talk about that real quick, just to, again, reiterate how complicated this genotype-phenotype discussion is. If I have, again, a mutation in one of my alpha-3 chains, I might, on the one hand, call that autosomal recessive Alports, right? Or might be, or I might call it autosomal dominant thin basement membrane, right? Because that one mutant allele is still causing a disease presentation. It's just a benign disease, right? Again, complicated nomenclature, right? If I have a family history of hearing loss, eye abnormalities, or renal failure, obviously that's pointing towards Alport syndrome. Now, I can also use the skin biopsy to make the distinction between thin basement membrane and Alports. I can use a renal biopsy. In X-linked Alports, remember, these individuals will typically have that negative immunofluorescence for the alpha-5 chain if I'm a male with an abnormal alpha-5 chain in my type 4 collagen, right? I can look for that on skin biopsy, right? And then in thin basement membrane, right, I will see that alpha-5 chain if the thin basement membrane is arising from a mutation in the alpha-3 chain or the alpha-4 chain. Okay? All right. Renal biopsy, they may have thin basement membranes in the early phase of that disease, right? But if I'm starting to see a lot of FSGS and that basket weaving, I'm more likely to then call that Alport syndrome. Okay, so I'll just gloss over the remainder part of that. Okay, of course now we have genetic testing that can also help you in making these distinct diagnoses. Okay, treatment, ACE inhibitors, and then if you have a patient who has pain with hematuria, you can try certain measures like uh, um, trying to treat the hypercalciuria or hyperuricosiuria to try and reduce the rates of gross hematuria. Okay, And now again, there's some trials, randomized trials that are underway for treating these diseases of glomerular basement membrane.